ZSFG has been an essential community service in San Francisco for more than 150 years. We are the city's safety net, and what that means is that we embrace all of the people in the city who really would have no other place to get care. People whose health and wellness is determined by social determinants of health. And we not only embrace taking care of this population, but we're constantly looking for ways that we can improve our care.
In 2017, the health system was dealing with several issues related to high readmission rates. As we investigated the problem further, we realized that there were significant inequities in the way that we were caring for patients with heart failure.
When we looked at our data to see why we were the worst performing in the state with respect to heart failure readmissions, we noticed that our care to this population wasn't always the same from person to person. And we noticed that we had a huge disparity among Black African American men. And when we dug further into why that was the case, it was because a lot of these men had substance use disorder as the root cause for their heart failure, and we weren't doing enough to address that particular problem.
Many of the higher risk patients not only have heart failure and severe illness, but also are affected by socioeconomic barriers to care.
That becomes very important then, because if you don't address the social determinants in your care path, you're not going to improve outcomes.
And so I, along with several other people, were tasked with developing an approach to try to reduce our readmission rates without worsening health equity. We needed to both implement a standardized approach, but we also needed to give additional resources to our highest risk patients.
Whether it's heart failure or hypertension or tobacco use, we know what best practices are. And when you're in a resource-limited environment, how do you identify patients that are higher risk, and how do you focus the resources that you do have on that population?
So ultimately what we did is we developed a predictive AI algorithm that helped to predict readmission amongst our heart failure patients. And that allowed us to risk stratify our patient population to understand who were our highest risk patients, to proactively look forward, to try to predict who would get admitted to the hospital in the future and focus more proactively on those patients. What we have seen is we've gone from the safety net hospital with the highest readmission rate in the state to now the lowest, or one of the lowest, depending on the month that you look at. And we've seen a significant closure in equity gaps in terms of our readmission rate in our Black African American patients with heart failure. So the fact that we in this health system, in a safety net hospital, have been able to develop our own tools internally and utilize that to positively improve patient outcomes and improve health equity is something that I'm particularly proud of.
What we've been able to show with this modeling and with this work, it's not specific to heart failure. Once we have this kind of core in place, it does allow us to think about other disease processes. And the way it's structured, it can be modeled to any public health system that we've targeted for San Francisco, but that's going to be different than Los Angeles or New York or somewhere in between. But it's built in such a way that you can integrate the data from that local population and adjust the model to identify the high-risk patients there.
We can think of this as a really complicated project that used artificial intelligence to understand what the patient's needs were. And we can also think of this as simple algorithms applied in the health record that can allow people to do the right thing more of the time.